Thank you, Dr. Abdul Fattah, Sam, for your nice presentation and presentation in Yemen. This is the good job you work. أسئلة بعدين بنسأل.
Next speaker, Dr. Abdul Fattah. Pubic cervical plexus blocks for carotid surgery. Safe and effective approach. Dr. Abdul Jalil. Dr. Abdul Jalil.
إذا مش موجود بنبدأ بالأسئلة. إذا في أي حد عنده أسئلة، أنا عندي سؤال للدكتور عبد الفتاح التام. دكتور عبد الفتاح. دكتور عبد الفتاح بنبدأ بالأسئلة. السؤال موجه لك. When you do fingers implantation, you do only arterial anastomosis or only, also venous anastomosis?
For what? For the finger. For finger, you should to have at least one vein or and two arteries. At least one vein. If you have two vein, is best. But sometimes if you have multiple fingers, you have no time. We do artery there, artery, then start vein.
Okay, thank you. Next question about hand.
Hand, yes.
Implantations. I didn't see any fixation for bone. How you?
Yeah, the first step is bone fixation. But ما نخليش اصحاب العظام ياخذوا راحتهم بالفكسيشن ولا عشان نعمل ريبير. So they put mostly keyword fixation.
أنا شفت الحالة إنه اليوم الثاني من العملية فقط يعني you did vascular anastomosis.
لا first bone fixation should be first. Yeah, small key wires
inside.
بس ضروري you should fix لأن الاسموسيس بيتحرك عليك.
Okay, thank you.
شكرا جزيلا.
Any question? Yes, please go.
حبيبي الروح.
With respect patient بس الدكتور ماهر الغاراتي بالنسبة للبيشنت كريتيريا for refer for carotid endarterectomy الاوت كم كيف يعني لو في بيشنت 50 60 سنة واشتي يدخلوا endarterectomy carotid endarterectomy الاوت كم يكون بنفس الجود هذا فايش الكريتيريا على سبيل انه اي بيشنت with ischemic CPA حولوا ل endarterectomy carotid endarterectomy
هو في هاي ريسك فور سيرجيكال انترفنشن.
دكتور منذر هذه الجلسه الاولى.
ايوه بس ما لحقناش لانه ما شافنيش سوري يعني.
في هاي ريسك كريتيريا فور سيرجيكال انترفنشن بس اللي هم اكثر من 70 سنه هذولا حقهم الخمس سنوات انهم يعيشوا 5 سنوات قليل جدا فما عاد ينفعش معاهم الكاروتيد اندرتكتومي. افضل لهم نعمل لهم ستنت افضل من الكاروتيد انترتكتومي. البنفيت تكون كبير والباتنسي نفس الباتنسي والريسك مع الكاروتيد انترتكتومي السيرجري كبيره شباب فالافضل لهم ستنت. بس مش مشكله لا 70 سنه باخذ دراسه حق الايكاست والكريست 1 و 2 ما فيش مشكله خالص. اقل من 70 سنه اكثر من 70 سنه الافضل انه الستنتنج.
شكرا لك.
Thank you. Yes, Dr. علي. Professor علي.
أنا بالمؤتمر يا أخي thank you for معلش أنا بس سؤالي سؤال واحد هو البوست اوبريتيف ريهابيليتيشن ومركز الأطراف عفوا ريهابيليتيشن ومركز الأطراف وماذا احنا نساوي للآخرين يعني إيش نعمل يا أستاذ؟ ماذا قدمنا لك؟ ماذا عملنا لك؟ يا أخي ذي يد حمد نخبز بها نخبز ونعصب. طيب الريهابيليتيشن هذا موست امبورتنت. مركز الأطراف لازم يعينك يعني الفاسيلتي لازم تكون وتوصية من توصيات المؤتمر انه كود بي تاخذ بعين الاعتبار يعني الفيزيوثيرابي فيرست ريهابيليتيشن سكند وبعدين السنثيتيك لو احتاج لانه المسك هو لو كان المسك كمان فيميل منين عنا ناكل خبز منين عنا عصد منين عنا
Thank you دكتور علي. حقيقة البحث المقدم من الدكتور عبد الفتاح التام يجب انه يكون حاصل على افضل بحث في هذا المؤتمر. البحث البروفيسور الدكتور علي الربوعي، الدكتور ابو زيد الكندي، الدكتور كيرلس الغطاس، الدكتور علي فاضل، الدكتور عبد الحميد الحنش، بليز يو كان كم.
احسن سبورت. ما يجي الان.
الو السلام عليكم. السلام عليكم دكتور زهير الحلس، كيف حالكم؟ تسمعونا؟
السلام عليكم، اسمعكم. ايوه هلا.
اهلا وسهلا فيكم. والدكتور زهير الحلس يعتبر من اكبر الجراحين العالميين، ها، وعضو جمعيه الجراحين العالميين، وعمل لدينا في اليمن اكثر من مره في زياراته، وعمل عمليات نوعيه ومعقده وخاصه، ونشكره على كل ما عمله لابناء اليمن. الدكتور زهير الحلس يقدم لنا الان surgical treatment of anomalous coronary arteries. فلتفضل. تفضل يا دكتور.
اوكي. Can you see my screen?
عم نشوفكم كويس. السكرين كويس واضح. شيرينج. تفضل. ستارت.
تمام. اوكي.
زهير تفضل.
ايوه. السلام عليكم.
عليكم السلام.
Inshallah, today I will talk about surgical treatment of anomalous coronary arteries. As we all know, these mean that the coronary arteries are coming outside their normal location. So we have two major groups: anomalous origin of coronary arteries, that they are not coming from the aorta. And the most common example of that is the anomalous origin of the left coronary artery from the pulmonary artery. And then we have the coronary arteries arising from the aortic root, but they're not from their original or normally described position. This is just a diagram that demonstrates the possible anomalous location of the coronary arteries. As you can see here, we have the aortic valve leaflets. This is the aortic root, and this is the pulmonary root. And the yellow denotes the left coronary artery anomalies, and the blue is the right coronary artery anomalies. So we can have either coming from the pulmonary artery, either the right or the left. Most commonly is the left. Then we can have anomalous origins from the both coming out from the not their normal coronary sinus. And then we have anomalous coronary coming out from the different sinus, and the right coronary coming from a different sinus. So we start first with the anomalous origin of coronary arteries not from the aorta. And as I mentioned, the most commonly is the left coronary artery arising from the pulmonary artery, or what is known as the Al-Kaaba syndrome. Other uncommon anomalies. Is also other coronary can arise from the aorta, either the right, even in occasionally the circumflex. And as we know, as a result of this, there is an area of myocardial damage that occurs. People think because if it is the cyanotic, blue blood that comes to the coronary, to the myocardium. However, it's usually the shunt, the steel, that causes the myocardial infarction and the myocardial damage. This is very important to realize because if not treated, prognosis is poor. If not treated, prognosis is poor, with about 80 to 90% mortality rate by 1 year of age. The ischemic consequences are variable and depend upon two main factors: the coronary dominance, if there is a dominance of the left main, particularly the circumflex coronary artery, and then the development of intercoronary collaterals that may develop. And if these collaterals develop, that may allow survival into adulthood. And actually, we have seen patients in their 30s with anomalous origin of the right coronary artery and with normal left ventricular function, mostly related to the presence of significant collaterals. In general, surgical correction is indicated as soon as the diagnosis is made, and this is, of course, to promote earlier and quicker recovery of the left ventricular function. Associated with the disease, mitral valve regurgitation, which can coexist, and this may improve after the repair. However, in some patients, mitral valve repair can be indicated. This is an example of one of our patients, as you can see here, a 2-year-old male who's very symptomatic with heart failure. Initially, as a child, the patient was managed as dilated cardiomyopathy secondary to viral myocarditis, as he has a history of upper respiratory tract infection preceding the development of heart failure. And he was actually referred to us for evaluation for heart transplantation. However, the presence of Al-Kappa was suspected. And as you can see here, the coronary angiogram shows a dilated left coronary arising from the pulmonary artery. Patient underwent repair with good recovery. Now, repairing this anomaly is generally reimplantation of the coronary. We take out the coronary from its origin in the pulmonary artery, and we transfer it to the coronary. Sometimes this can come directly easily. Other times there is a gap, and this we have to bridge the gap by some sort of tissue to try and let the coronary aorta without amputation, and this is the sinus is repaired. This is this particular patient function after full recovery, and you can see it's a normal left ventricular function with no mitral valve regurgitation. There are several surgical techniques that have been described to repair. In the old days, they were talking about ligation, but this results in significant mortality. Coronary artery bypass grafting, utilizing the coronary bypass grafting, utilizing the left internal mammary or the left subclavian artery. And however, everybody nowadays transfers the coronary back to the aorta, something that we call the approaches to establish a dual coronary artery system. The earliest type of surgical repair is the Takayuchi repair, where actually an intrapulmonary tunnel is constructed, and this tunnel is connected to the aorta to route the blood from the coronary artery, from the aorta to the coronary artery through this tunnel, which remains inside the pulmonary artery. This procedure is associated with some leaks and stenosis and etc. So it fell out of use, and most of us nowadays utilize the direct transfer of the coronary to the aorta. As I mentioned, sometimes there is a big distance, and then you have to utilize techniques to try and make it longer. Some of these take advantage of the pulmonary artery. Others use other autologous material for the connection. We looked at our surgery, our results doing what we call the reestablishment of dual coronary artery system. And actually, this was very good, as you can see here. In most of the patients, we use direct connection. In some patients, we use the other extension techniques, and you can see that the survival at 10 years was normal compared to the normal population. We also looked at some other parameters, and you can see here that the recovery of the patients has been very excellent. Looking at the left ventricular and diastolic pressure, the left ventricular and diastolic pressure that came back to almost normal in all of the patients. So in general, the outcomes were excellent. All surviving patients except one had improved exercise capacity. A New York Heart Association functional class 1 to 2. Ejection fraction improved from a mean of 0.32 to a mean of about 0.64, highly significant. The left ventricular and diastolic volume dimensions decreased from 9. Can imagine how big was the LVs, to almost normal. Mitral valve regurgitation was absent to mild in 24, and moderate in 3 survivors was about 11%, compared to 70% with moderate to severe MR before surgery. So overall, excellent outcomes, and therefore, once this diagnosed, surgery is indicated. We just had a very rare case that we operated upon, where actually the Al-Kappa was associated with tetralogy of Fallot. And this patient had severe biventricular dysfunction, and after the repair, he had also full recovery. You can see it here, Al-Kappa coming from the pulmonary artery, and features of tetralogy of Fallot. Now we go to the anomalous aortic erosion of the coronary arteries. This is where the coronary arteries still arise from the aorta, but from an anomalous location. And all 3 coronary arteries may be involved. And unlike Al-Kappa, these involve anomalies of the aortic origin, as I mentioned, from the aortic root. The problems that are related to this, the problems that are caused from this are related to the anatomic course, the possibility of coronary stenosis, the possibility of compression, and this, of course, any of these may result in ischemia, and this may also lead to sudden death. These anomalies are often found in young patients who collapse and die while participating, most probably in sports and in exercise. And therefore, it's very important, particularly now in schools, when students are involved in sports, they're evaluated to make sure that they don't have this, or of course, HOCM. Most anomalous aortic origins are considered non-threatening to life, except these, if the anomalous origin of the left main coronary artery comes from the right aortic sinus of Valsalva. This is referred to as left from right. And the other also threatening condition is the anomalous origin of the right coronary artery from the left sinus of Valsalva. We refer to it as right from left. And of course, these can be associated with cardiac symptoms. They also can have no symptoms, but can lead to sudden death. And unfortunately, sudden cardiac death in some cases may be the first symptom of such an anomaly. However, increased awareness and improved diagnostic modalities have brought more of these patients to the attention of the clinicians, and hence to therapy. We look first at the right coronary artery arising from the left aortic sinus of Valsalva, what we refer to as the right from left. And these represent 6 to 27% of all coronary anomalies, may cause symptoms of angina, myocardial infarction, syncope, or even AV block. And this is the reason that this is dangerous or causes symptoms, because it is characterized by a slit-like stenotic orifice within the left coronary sinus. Then the right from left, it is also associated with an intramural course. And this is again can lead to ischemia, where the artery is running within the wall of the aorta before it exists in the right coronary sinus en route to the epicardial surface. The coronary artery may be compressed between the aorta and the pulmonary artery. Looking at the left from right, this is considered the most serious anomaly of coronary origin. It is associated with high incidence of symptoms and sudden cardiac death. There is intramural course in most of the cases, which can be above or below the commissure between the right and the left coronary cusps. Some special rarely encountered situations where there is an anomalous aortic origin of the coronary artery with a non-intramural course with malignant course between the aorta and the pulmonary artery. And this is actually sometimes we see after repair of transposition of the great arteries, because of course, to do the repair, we have to take the coronary arteries from their origin and then implant them into another route. And this can be a very challenging diagnostic dilemma. In these cases, a reimplantation strategy is applied, moving the coronary artery to a new orifice, to an unaffected site of the ascending aorta. And this, of course, this will require significant coronary artery mobilization to avoid kinking and stretch. And you can see here one such an example. This is the aorta, this is the pulmonary artery, and you can see the course here where the takeoff, I don't know if you can see it clearly, but this is clearly compressed by the pulmonary artery, leading to ischemia. This is how it looks. This is the left cusp, the left main coronary artery, and then we have the right coronary artery coming from an anomalous origin and going between the aorta and the pulmonary artery, causing compression. This is anomalous aortic origin of a coronary artery without intramural course. These are actually the simplest to repair, where you can simply excise the coronary artery orifice with some aortic wall tissue from around it to allow for suturing, and then connect it to a different location where it will not be kinked or compressed by other things. Again, these are some other techniques to try and get rid of the pulmonary artery, to prevent from the pulmonary artery from compressing the aorta. This is the normal location. The pulmonary artery is disconnected, and then an opening made towards the left, and the whole pulmonary artery is transposed to the left, away from the coronary artery to prevent compression. And this is afterwards is repaired, as you can see here. Sometimes a patch is added to prevent stretching or stenosis. And this is a complex way, actually, of trying to get rid of pulmonary artery compressing the coronary artery. But sometimes, if this is proven symptom, then it's worth doing. If we have a right coronary artery, coming from the left coronary sinus of Valsalva, we simply, as you can see in the diagram, this is the you can see the course of the vessel, and we simply unroof the coronary artery. We unroof the coronary artery and then allow the orifice to be enlarged a little bit, so there will be no compression of this intramural part. Right coronary artery from the left aortic sinus of Valsalva, the same thing, we try and unroof. Occasionally, this comes below the commissure. Then you have to do 2 openings. And actually, sometimes we even dislocate the commissure from the aortic wall, do the unroofing, and then reattach the commissure back into the aortic wall. There are really many surgical tricks and techniques to repair these anomalies, and one has to deal with the situation as he is facing it in the operating room. For instance, here, where actually the commissure is involved, you can unroof the artery, pull out the commissure, and do the procedure, as you can see here. Sometimes even the commissure itself can be relocated left or right to try and take it out of the pathway of the coronary artery. Left coronary artery from the right aortic sinus of Valsalva, again the same thing. You can see here in this diagram the commissure is in the way. Again, we dislocate the commissure, open up the vessel, and allow it unobstructed the flow of the artery, avoiding any compression. This is just one has to be very careful. This is just to make sure that there is no bleeding from the suture line, and there are some tricks to try and deal with the bleeding. This is another way of opening up an anomalous coronary. The orifice might be small, and we tend to patch it to make it wide open. Generally, if in these situations, if a patch is needed, what I do, I just borrow a patch from the aorta itself from another location, because there is always plenty of tissue, and a small patch can be easily harvested, and this would allow you to do the repair with totally autologous tissue. So in general, these are the recommendations for this anomaly. We look one, individuals with suspected anomalous origin of aortic origin from the coronary arteries should undergo transthoracic echocardiography to identify the origin and course of the proximal coronary arteries. So echocardiography is the first line of trying to diagnose these. Additional imaging studies such as coronary CT angiography or cardiac MRI are reasonable to better visualize the coronary artery anatomy and to confirm the diagnosis. This is a class 2A level of evidence. In those individuals without a history of ischemic chest pain or aborted sudden cardiac death, exercise stress testing combined with a nuclear perfusion scan or echocardiographic imaging should be used to help assess the potential ischemic burden of the anatomic variant. And this is a class 1 level of evidence is B. I don't know, but if you face this problem, usually the patients are very reluctant when, even if you explain to them, they're very reluctant, and sometimes they're not convinced that this could be the source of their problem, and therefore these additional modalities of trying to diagnose the anomaly are very important. Cardiac catheterization is probably the last thing that you need to do to confirm the diagnosis. And this is with anomalous origin of a coronary artery if the anatomy cannot be defined with non-invasive imaging. And in adults with risk factors for coexistent atherosclerotic coronary artery disease. So we go echo, maybe CT, MRI, and then cardiac catheterization if required. So to summarize, these conditions are rare but important anomalies that, if untreated, may lead to significant morbidity and mortality risk. Surgical treatment is considered curative if performed by skilled, experienced cardiac surgeons. And this is really very important. You cannot be an occasional surgeon not seeing cases and do this successfully, because they're really can be very, very critical. And it's really a shame if you take a patient to the operating room to solve the problem and end up with the same problem. Thank you very much. And if there are any questions, I'm happy to answer.